Hi everyone, it's Nigel Giam here, the lead GP training program director of the St Mary's Scheme and course director for Mentor MRCGP. It is lovely to have the lovely Eesha join us today to talk about her success story in the recent autumn SCA sittings. Eesha, it's lovely to see you. And firstly, a massive congratulations. I know this was quite a big worry, the SCA, in getting through it, but well done. You got through the exam and actually you smashed the exam. I mean, this was like about 16 marks or so above the pass mark. I mean, it was a very impressive score. Do tell the audience a little bit about yourself, how you got into general practice training, and then we can get into the SCA technique. Do tell us a bit about yourself.
Definitely. Thank you. Thank you firstly for all your wishes and the work with me. I
That's all
really
right.
appreciate it. With regards to myself, well, I'm an international graduate. I've studied in India and then I've worked in different places of the world. Did a little bit of acute medicine and then I moved into general practice after COVID. I've quite enjoyed it. A little bit as a setback, personal setback, and then the great help with the exams. So thank you so
Oh,
much.
pleasure. It was an absolute pleasure to work with you. And actually, it's quite interesting because I think when we had you on the masterclass and then the subsequent one-to-ones, I mean, I know that you were slightly nervous coming on the masterclass, as a lot of people are, but it was lovely to kind of see you grow in confidence with our one-to-ones. And I was very happy to hear about the result. But actually, to be honest, I knew you were going to pass. To be fair, I think you've
Thank
done a lot
you.
of really smart work. And I think it is about working smart. I know a lot of our audience out there will be listening and they might be a little bit disheartened because they might have just received their results or failed again. I do, as you know, tutor a lot of IMG students, and I think there are quite a lot of mixed messages, unfortunately, about the exam. So I thought this would be a really good opportunity to think about your game changers. If you're saying to someone who's either preparing for the exam for the first time or going in, what needs to kind of happen to maximize your marks in the three domains. So perhaps we can start with data gathering. What would your top tips be for our audience listening as to how to maximize marks here?
Um, there's a lot going on in data gathering. It's a very tight nugget, super tight, I would say. So specific questions, contextual questions, and ICE isn't just enough, is what I wanted to
Yeah,
say. There's a lot with the patient's situation, the story, the
yeah,
theme, narrative that we'll need to bring in,
yes,
and we just have to follow the cues.
yeah. So the cues are the king queen of the consultation. So I suppose it's interesting when we say ICE is not enough because the concept that we worked on is something called LICEF, which for our audience stands for not just understanding ideas, concerns, and expectations, but how it's impacting a patient's life, their circumstances, their situation. And often patients will, you know, have feelings and emotions that go along with that, which we need to acknowledge rather than process. Um, I don't know if you remember what your processing word was on the course. Do you remember what it was?
Darling. Thing.
So I think we talk about processing as not really being present, okay, fine, right. Whereas you got a lot better with this through AEE, which we'll talk about, I suppose, a bit later when it comes to relating to others. Um, in the context of case priming, what did this mean for you? What does it mean for our audience? Because I think a lot of people don't really understand what case priming is about.
Oh, this is super important. It gives us a power-packed performance entry into the consultation, proves that the doctor's confident, they've
Yeah,
looked through the notes.
yeah,
There's a lot on the notes out there, which is not just past medical history.
yes,
It's got to be compared with the blueprint,
yeah,
and then that's how thought formulation can
yeah,
happen.
yeah, yeah,
And one can negate anxiety with that and just
yeah.
enter the consultation nice and easy.
Yeah, and I think that's really important, isn't it? Because actually, when you're in a high stakes exam, you do get anxious. So the problem is when you get anxious, you start symptom chasing, and then, as you said, questions are asked out of context. Smoking, alcohol, it's like, what's that got to do with the conversation that we were just having? You know?
Absolutely.
So this aspect, I suppose, of curiosity cues conversation, and so this is a new acronym that I haven't taught you. I don't need to teach you anyway because you've passed now. But we call it the three C's: curiosity, cues, and conversation. And that's the heart of having a narrative-based consultation. If we move on to clinical management, I think what's interesting is people have been sold it as clinical management, but actually kind of management of the situation, isn't it? Um,
Absolutely. There's a
yeah.
story there.
Yeah. And I mean, if you think back, I suppose to obviously we can't discuss the intricacies of any case that you did, but in terms of the context of the patient, if you could maybe give us an example of how you managed a patient as opposed to just a symptom or a diagnosis, does anything come to mind at all?
hmm Um, I do want to say I had a patient with not in the exam, but
Mm.
just generally while practicing.
Yeah.
I had a patient in real life where um, they just wouldn't open up.
Yeah.
I
Yeah.
felt like in the exam, opening doors was also really hard.
Yes.
Um, I think silence would take one in a long, long way
Yes.
because there is the father clock at the back.
Yes.
Ticking, ticking, ticking. And
Yeah.
what happens to most doctors, including me, before I actually looked into it, was that we just tend to talk a lot.
Yeah. I know. Right.
It's all that anxiety pouring out. So,
Yeah.
um, signposting, bringing them back,
Yeah.
negotiating, having
Yeah.
that dilemma address, having the risk address. It's a lot. It's a lot
Yes.
of management.
Yeah. Yeah.
Getting there early,
Yeah.
and using certain skills,
Yeah.
intermingled with interpersonal skills, would take
Yeah.
us a long way
Yeah.
in managing the management aspect. It's the
I
ball.
find that actually really interesting because we haven't really necessarily touched on that with previous interviews about the use of silence because actually it goes back to that golden phrase of silence is golden, isn't it, when used in context? I mean, for example, if you've delivered a potentially serious diagnosis or you're trying to exclude something serious, I mean, cancer is a big word, isn't it? I mean, in real life, in the exam, that action is going to have a reaction. And once you're in the clinical management section, our tendency is then just to want to talk out the patient, what's going to happen, but actually we can't. We've got to manage the patient. We've got to manage their feelings. We've got to manage their emotions. So I think thank you for bringing that in actually, because that's really, really important. The use of silence actually sometimes in clinical management, that facilitation of how we move the consultation forwards is very important. I think a lot of our audience will also be quite worried of, well, what if I don't know what the diagnosis is? What do I do? What's your response to that?
Well, there's always going to be uncertainty in real
Yeah,
life too. And it's all right to not know the diagnosis.
exactly.
It's
Yeah,
all right.
yeah,
You have to sit tight with the anxiety
yeah, 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 yeah,
and then just swim through managing expectations, the
yeah.
situation, sort of educating the patient, and getting into safe waters.
Yes, I agree because actually, when we, for example, are referring on a 2 week wait, we're not saying this is definitely cancer. We're not.
Yeah.
No. And sometimes actually we don't know what's going on, but we have enough red flags to escalate it to try and find out what's going on. Or conversely, if there aren't any red flags, then we can't panic with that because I think the tendency is if we get anxious, everybody else around us is going to kind of feel that anxiety, aren't they? Um,
Absolutely. And that's where I remember the other abbreviation, AEE,
oh yes, we worked on AEE a lot. So
everywhere.
yeah, yeah. So as we move quite nicely, segue into relating to others, AEE, the glue that holds everything together, acknowledging, empathizing, energizing. Um, have you felt that you've been able to apply these skills in real life as well? I'm interested to know.
Oh yes, my consultations have gotten better.
Yeah.
You've changed my life, as I think I would say. Thank you for being my role.
Oh, so sweet. Well, I mean, it's interesting because I know when we were doing our kind of masterclass and one-to-ones, we'd always start with a bit of tentative energy, it's like,
Yeah.
oh, but actually it's so nice to kind of see you on the other side, all like really smiling and happy but actually it's so important that we bring that energy into what we do in everyday life. The doctor is the drug, but also in the exam, they want to see who you are really as a person, don't they? Um, so I suppose as we kind of end, just in relating to others, how did you find the simulators? I mean, you've mentioned some of them were quite tough to unravel. What sort of advice would you have for our audience about how to maximize relating to others?
I do want to say that they're there to help you because they have a lot of questions. They
Yeah,
want to talk to you.
yeah, yeah, yeah.
And if we don't involve them, the other thing that we used was a ping pong.
Yes.
If we don't involve them at any given point, they're not going to open up and
No,
tell us
no,
things.
no, no.
So I think relating to others is not just about being nice
Yeah,
or listening to them. it's involving them from
Yeah.
then on taking the reins into the consultation, saying no if we have to.
Yeah. Yeah. Yeah.
It's also a lot of our negotiation skills,
Yeah.
and using the word dilemma does help.
Yeah, it definitely does. And that is our kind of big mantra on the course and indeed in real life because we're kind of faced with dilemmas every day. Isha, it's lovely to have you on. Thank you so much for sharing your experience and your lovely energy. And I'm sure our audience are going to benefit from this a lot. Do keep in touch, promise, okay?
Definitely.
And I look forward to seeing you and hearing about all your stories in real life general practice soon. Okay. Thank you so much.
Yeah.